Hi, my name is Brad Steinman. I'm one of the anesthesiology residents at University Hospitals Cleveland Medical Center. Today we're going to be going through setting up a cardiac OR. Starting off your cardiac rotation can be very intimidating. I hope this video can be helpful. We're going to be going through kind of an in-depth look at what stuff you need to have prepared for a case to start, as well as going through kind of the flow of how a case gets started, going on to bypass, coming off of bypass, and getting your patient safely to the ICU. Starting off cardiac can be very intimidating. But we're going to try to go through things step by step to make sure that you are adequately prepared for your first day. I do want to encourage you to get here earlier than you typically would. I think on your first day, getting here between 5:15 and 5:30 is inappropriate for a 7:15 start time. That seems pretty excessively early, but there's quite a bit of stuff to get set up, and your first time doing it will take a little bit longer. That being said, we're going to keep things familiar. We're still going to go through the traditional MS MAIDS formula. We're just going to talk about the stuff that's added with each one. So our first step is still our machine. Our machine check is going to be the same as always. We're still going to do our full machine check in the morning. We're going to make sure our circuit is hooked up, our vaporizer is set up and ready to go. In cardiac cases, we typically use isoflurane instead of sevoflurane. So we have the isoflurane cassette and hooked up to a ventilator, and our sevo's up here in the extra slot. Everything else is going to be set up the same for our machine. Our suction is also going to be the same. We're going to have our suction available and ready to go, hooked up to our Daytower tubing. So that first M and the first S are pretty much the same. We just want to make sure we have our isoflurane hooked up into line. Our next M is our monitors. That's where we start to add a couple things in our cardiac cases. We still have all our standard monitors here. We have our pulse ox, our blood pressure cuff, our EKG leads up here. We do have some additional monitors that we do like to use in the cardiac rooms. This device up here on top of the machine is to use to look at cerebral oximetry. We have these special stickers right here that you will place on the patient's forehead to help look at perfusion to the brain and oxygen content in the brain. These stickers attach to this device right here, and you will put these stickers on the patient before you go off to sleep. We also additionally want to make sure we have our triple pressure bag set up and ready to go. These can be found in the workroom. They look similar to the pressure bag, except they have 3 of these transducers instead of the 1. We also have this very handy holder that is going to hold all 3 of our transducers. We have our arterial line transducer, our CVP transducer, and our pulmonary artery pressure transducer here, connected all 3 to our triple pressure cable. Additionally, for our monitors, we want to make sure we have our TEE probe and machine in the room. This is our transesophageal echo machine right here. We have this in the room. Some attendings do prefer if you leave it out of the room until it's time to be used. I would say the majority would prefer if it's in the room in case it gets started, so I would say it's safer than not to have it in the room ready to go. We also, from our workroom, we grab our transesophageal echo probe. There's usually 1 or 2 set up in the workroom ready to go. This indicates that it is clean and ready for use. We're going to keep it clean here. It's set up and ready to go. If there are none available, there are some probes that are in the cabinet behind the desk that you can grab and place in here. Make sure you keep it clean. If you're also going to set up your own kit, make sure you grab the red sponges and the mouth guard so that you can put it into the patient safely. That's it for our monitors. Next, we're going to talk about our airway. When thinking about our airway for cardiac cases, we are normally okay to do the kind of traditional airway setup with our mask, our blade, our tube. If you think the patient has an adequate airway exam, you can do a direct laryngoscopy. If you think it's a poor airway exam, have a video scope available. This is going to be the case if you're doing a traditional sternotomy. A single lumen ET tube is going to be fine. If you start doing robotic cases or mini sternotomies or minimally invasive procedures where they're going in through the side, the surgeon may need selective 1-lung ventilation throughout the case, in which case you'll need to use a double lumen ET tube. If you're using a double lumen ET tube, they're found in the workroom. You'll get sizes 37, 39, 41, or the ones we always have stock back there. You'll pick the one that's correct for your patient. If you're doing a double lumen tube, you'll also need to have the fiber optic scope available in the room. The fiber optic scope is used to help confirm placement of the ET tube. Once it's in place, you will make sure that the bronchial lumens correctly down the left bronchus and the tracheal lumen is still open above the carina. So if you're doing a double lumen tube, make sure you have the fiber optic scope available in the room. If you're doing a traditional sternotomy, you are okay with your normal intubation setup with a blade, a mask, a tube. It should be all good there. We're now onto our I in MS MAIDS, which stands for IV. We're going to kind of broaden that a little bit and talk about all the access that we need for our patient, as well as some more fluids that we're going to use throughout the case. So for our peripheral IVs, we usually want to make sure we have 1 large bore IV before we go off to sleep. 2 would be great after we go to sleep, but we'll make sure we have 1 large bore IV to start off. We're also going to be doing pre-induction A lines for these patients, so we want to make sure we have our arterial line kit ready to go. We have these little two-tiered tables that are in the cardiac ORs. We always set these up with our arterial line supplies on the top and our central line supplies on the bottom. We do our arterial line first, so that's ready to go. Then we'll move our central line stuff up here. To make sure we're ready for our arterial line, we will make sure we have our A-line kit in here ready to go. Make sure we have our ultrasound probe cover. We make sure we have our ChloraPrep. You may need 2 of these smaller ones or 1 of the larger ones. Then we need to make sure we have sterile gloves in here as well. You may also want to grab some gauze just to help keep things clean. We also want to make sure that we have our ultrasound in here set up and ready to go. This is one of our cardiac ultrasounds. It's usually in the room or it's usually just outside the OR if it's not in the room. You want to make sure this is plugged in and turned on so it's ready to go when the patient rolls in here. Once we have finished with our A-line, we can move some of our central line stuff up to the top of the table. So we'll slide this up here. We'll make sure we'll go through this as well. So first thing we have is we have our actual central line kit itself. This is our MAC line. This is what we probably most commonly use for our cardiac patients. This has 1 introducer port and 2 additional ports through the central line. We'll usually use one of 2 things through the introducer port. We may use what's called a mini MAC, which is a 3-lumen central line that goes through the introducers that offers us, like I said, 3 additional lumens of central access. The other thing we may use is a Swan's-Ganz catheter or our pulmonary artery catheter. Make sure you discuss with your attending the night before on if they feel like a pulmonary artery catheter is necessary, so you can have it ready to go. And if you do place it, make sure you discuss with your attending practicing placing it. So it's a good skill to learn. We also want to make sure we still have our ultrasound probe cover. We want to make sure we still have ChloraPrep ready to go, our sterile gloves. There is a gown in here, but if your attending is going to gown up, make sure you have an extra gown with you. And then I typically like to grab a couple extra lure locks so that I can make sure we don't get any unwanted bleeding back through our central line. Moving on to our fluids, we need to make sure we have 2 IV pools in here. We need to make sure we have 1 IV pool with at least 6 channels on the Alaris pumps, ideally 8. You're going to be using most of them, so you want to make sure you have them in here and ready to go. We also want to make sure you have another IV pool available for our blood tubing, our push lines, or extra fluids if needed. Going through which fluids I typically run for a cardiac case, I'll usually have 1 250 cc bag of LR that I will run through the Alaris pump as a carrier fluid for our infusions. I usually hook it up to either up here or up here as one of the corner ones, and I'll run it at 50 cc's an hour, more or less, as a carrier for all of our infusion medications. I also like to have 1 liter bag of LR that's hooked up to our patient, which can be used as a push line or also used as like a fluid bolus if we need to get a bolus. And then lastly, I like to have blood tubing prepped and ready to go. So we'll have a liter bag of normal saline connected to our blood tubing and primed through the filter, through the warmer, so it's also ready to hook up and give to our patient if they need any blood transfusion products. Now lastly, the one kind of thing that we have with our IVs is we want to make sure we have our initial lab kit set up and ready to go. After we place our A-line, we will want to make sure we draw initial labs for our patient. To have our labs, we want to make sure we have a 10 cc waste syringe, like we typically have when we draw ABGs. We want to make sure we have a 5 cc syringe to collect blood, and then place in our blue top tube for our TEG. And then we want to make sure we have our ABG syringe as well for our ABG. It's important to note that you need to draw your 5 cc syringe for the TEG before you draw the ABG, as the ABG syringe does have heparin in it and can affect the results of the TEG. So that's it for our IVs. We'll next go into discussing what syringes and drugs you should have prepared for your cardiac cases. Moving on to drugs for our cardiac ORs, one of the first things you can do when you get here in the morning is stop at the pharmacy and ask for the cardiac meds for your case. They'll say you need the cardiac meds for room 18 or 19 or 21, and they'll give you a big pile of medications. What you typically get with your cardiac meds is norepinephrine, epinephrine, insulin, tranexamic acid, and phenylephrine. You can also additionally ask for clofidipine and vasopressin if you would like those for your case as well. So once you grab those, you can bring them to the room and you can start using them to make dilutions in syringes. Moving over, we have our syringes that we've prepared for our case. This is quite a few syringes. It's probably more than you're typically used to setting up, but we'll go through them as well. We usually like to have a heparin syringe ready. This is in our 50 cc syringe. When we give heparin to go on bypass, we give 400 units per kilogram. So it's usually a pretty high dose of heparin, so we need a large syringe for this. We have 20 cc syringes with propofol, rocuronium, and fentanyl. There is a 20 cc fentanyl vial in these cardiac Omnicells that you can pull out, and you typically in pretty large doses at a time, so you use a lot of it. For our 10 cc syringes, we have a lot of our vasopressor medication. We have epinephrine syringes, norepinephrine syringes for our vasopressors. We have esmolol and nitroglycerin to help decrease our blood pressure. We also have our Ancef syringe, and then depending on how we're doing our induction, we may have succinylcholine or etomidate syringes, depending on the stability of our patient. Before you move on from those, discussing the concentration of the syringes that we use for our vasopressors. So our epinephrine bags come in 16 mics per ml. We typically just draw that up without any dilution, and we keep our syringe at 16 mics per ml. Our norepinephrine bags, on the other hand, come at a concentration of 32 mics per ml. And so we typically dilute it down to 16 mics per ml. You would do that by drawing 5 cc's of the norepinephrine off the bag, and then adding 5 cc's of normal saline to the syringe. That would dilute it from 32 mics per ml to 16 mics per ml. Our nitroglycerin also typically comes at 200 mics per ml, and we typically dilute that down in half as well. So the same process. Draw 5 cc's of nitroglycerin, and then add 5 cc's of normal saline to it to dilute it to a concentration of 100 mics per ml. The esmolol we draw the same as always. We also want to make sure you have our lidocaine syringe ready to go, and then we'll also have Versed, glycopyrrolate, and atropine syringes available as needed. That is kind of the traditional stuff you'll need for a cardiac room setup as far as your drugs go. Like I said, make sure you have the bags and syringes prepped, ready to go. Now to kind of show you how we may organize this in our cardiac room, we're going to move over here and look at our pump. We've already kind of mentioned I usually like to use one of the channels up top as our carrier fluid. So let's just say, for instance, we use our D channel as our carrier fluid. I then just like to keep things organized. I know that I'm always going to be having norepinephrine and epinephrine in line. So I'll usually use my A channel and my B channel as norepinephrine and epinephrine. I keep it standard, that way I don't have to think about what's where. I will also throw labels up here so that if anyone else comes into my room, they can look and they can see and they can know without any shadow of a doubt what medications are running through each channel. We also usually like to have our TXA in line because we are going to run a TXA infusion throughout the case, and so I'll usually put that on the C channel. That means that my Topolaris pump I set up every time, and I set it up the same every time. My A is my norepinephrine, my B is my epinephrine, my C is my TXA, and my D as my carrier fluid. Everything else that I might add in addition, whether it's vasopressin, whether it's insulin, whatever it may be, nitroglycerin will go down on my bottom channels down here. This is also where I'll hook up propofol at the end of the case for our sedation. So other people may do it differently. This is just a way that I do it as a kind of a way to keep it standard so that I know what I'm doing when I'm in my cases and help me keep it straight when I'm doing cardiac cases. But you're more than welcome to find what makes you comfortable and helps you feel like you are well organized in these cardiac cases, because organization is very important when patients are very sick and when things are happening very quickly. Hopefully this is helpful. We'll keep discussing next about kind of the general flow of case start for cardiac cases and go from there. All right, it's been an hour and a half. You've been setting up your case all morning. You're finally set up and ready to go. You go pre-op your patient, you finish your evaluation, and it's finally time to roll back. It's important to get the patient back to the room on time. The cardiac surgeons very much like to have the patient in room on time, so make sure you're out there early enough to get the patient back here on time, usually by 7:15. Once you get in the room, you'll do your timeout with the surgical team, and then it's time for you to start some of your procedures. We typically like to start with our brachial arterial line, so you'll make sure you have your ultrasound ready to go. You'll have your kit already ready to go on the table like we've discussed, and you'll place your brachial arterial line. After the arterial line is in place, it's time for your induction of your patient. This is where you'll put your patient to sleep, and you'll typically intubate your patient. Usually, after you've intubated the patient, your attending will step in, and they will start to tape the tube in place. They'll tape the eyes, they'll place an OG, all of that stuff that needs to be done that you would typically do after a case, so that you can go scrub in and get prepared for your central line. While this is all getting done, you prepare for your central line, you get your kit ready to go. Usually by the time you are all clean, you have the kit open, it's time for you to get started. You'll place your central line. This is a really good rotation to get a lot of that practice in there. Once your central line is in place, then it is in time for you to kind of get organized. Get all your drips hooked up to the central line, get your lines organized, make sure you have all your monitors, your invasive monitors connected, so you can be set up and ready to go when the case actually starts. There are different ways to organize the way you hook up to your central line. I'll discuss with you how I like to do it. In most cases, I would say you have your MAC line, and in your introducer port, you have your mini MAC, which means you have 5 lumens available to you through your central line. I typically like to reserve my large white lumen on my MAC line as a push line. So I'll hook up my liter bag of saline, I'll add my fluid to it with an extension tubing and a syringe, so that I have push tubing on my white port. My brown port on my MAC line, I like to save and reserve for my blood tubing. So I'll hook my blood tubing up so that if I need to transfuse any blood throughout the case, it is already set up, primed, ready to go, and I'm ready to give blood to the patient immediately. That means we have 3 ports left through our mini MAC where we can hook up different things. The white port on the mini MAC I usually use as my infusion line. I make sure that I have one of the Octopus ports available. This hooks up directly to the white port on the mini MAC, and then you can hook 6 infusions up to it. So this is where I will hook up my norepinephrine, my epinephrine, my TXA, insulin, propofol, whatever you may need throughout the case. You can hook it up here, and it will infuse right into the patient. The blue port on the mini MAC I like to use as my CVP line. So I'll hook up my CVP pressure cable to that, make sure it's zeroed, and there I have my CVP line. That usually leaves me 1 open port, the brown port of the mini MAC, and that can be kept open if you need it. Sometimes I'll hook my sedation up there at the end of the case so that I know my sedation is getting in and it's not mixing with the other medications. That's the way that I typically like to organize it, but there's many ways to do it. You can find what works best for you. When you're getting near the end of your bypass time, make sure you have a couple things ready to go. You want to make sure that if there are pacing wires placed, that the pacing wires can be passed up to you, then you connect them to your pacer box, and that is adequately pacing if needed at this point in time. You also want to make sure that you are ready to turn the ventilator back on, you're ready to turn your monitors back on when you come off bypass as well. And lastly, when you know you're getting very close to coming off bypass, it's appropriate to draw up your protamine. Some people like to have it in a syringe, other people like to inject the protamine into like a 50 or 100 cc bag of saline and then run it into the patient. If you do that, please be very careful. Do not hook the bag up until it's time to get the protamine, and do not have the syringe sitting out ready to give until you are ready to give to the patient. Giving protamine while the patient is still in bypass can be catastrophic, and you want to make sure that you're being as safe as possible. If I draw my protamine up and then there's a delay in the case, or there is something where it's not time to give it, I make sure that I lock my protamine away so it is not available for anyone to reach or give to the patient until I know that I'm ready to give it and then the surgical team is ready for me to give it. So make sure you're very safe with your protamine. That being said, when you're coming off bypass, you're typically going to be starting your patient on some pressor agent, usually epinephrine, with some combination of norepinephrine or vasopressin. So usually make sure you get those started and going as well. Your attending is going to be in the room performing echo procedures to see how the heart is functioning as you're coming off bypass, and you'll kind of work together as a unit to come off bypass safely. It can be very overwhelming at first. A lot of things happen very quickly, but just be listening, be very attentive to the surgeon, be very attentive to your attending, and things should hopefully go smoothly. Once your patient's off bypass, the next kind of steps are getting prepared to transfer to the ICU. So make sure you are, once again, getting your lines organized, you have your sedation hooked up, and you're getting ready to move to the ICU when the surgical team is done. That being said, this is kind of most of the setup that you need for a cardiac OR. It can be quite a bit. Your first day can be a lot. Hopefully your TE senior will be available to help you set up or be there throughout the case to answer questions if needed. If not, please ask questions to your attending. They're all very helpful. Make sure you are using them as a resource that they are meant to be. Good luck on your cardiac rotation. It's very fun. It's not as stressful as people make it out to be. It's just very overwhelming the first day. So have fun, and I hope this video can be helpful.